So I am Tina Hesson, and I'm part of the 33N team who support CLEAR. And I've also been working with the team who've been undertaking the impact evaluation. I'm going to just spend a 1 minute to give you an overview of CLEAR in case not all of you are familiar with the program. And then I'm going to hand over to Jack, who's going to lift the lid on what impact assessments are all about. What value do they bring? How do you do them, etc. And then John will sort of do a deep dive into what the impact assessments that we did on the CLEAR commissions have told us about the value and the impact that the CLEAR program brings. And then we'll finish off with some Q&A, and then depending on how many questions you've got, we might finish a bit before time. I think we have an hour allotted, but we might not need it all. But if you've got lots of questions, then we're here for the hour. So should we flick on to the next slide? I think just next one. Yeah, so I think it's next one again. Brilliant. So as I said, I'm just going to start with a very high level snapshot on what CLEAR is. Essentially, CLEAR stands for Clinically Led Workforce and Activity Redesign. It is a nationwide and work-based program designed to improve patient care by putting clinicians in the driving seat of healthcare decision-making and innovation. And the genesis of the program is that clinicians are trained to use big data analysis to deliver models of care and workforce redesign. And essentially, by bringing together the trio of improvement methodologies and analytics and education, it enables frontline staff to deliver and innovate workforce redesign that is aligned with the priorities of the system, such as the goals of the NHS plans, long-term plan, triple, quadruple aims, etc. So that's the the genesis of the CLEAR program. And I think we've gone to the next slide. So essentially, how does it actually work? Well, essentially, the CLEAR projects that typically run over a 24-week period are delivered under the supervision of the CLEAR national faculties, with the mentors supporting the associates on the program. And in terms of what we've achieved so far, well, the program will have delivered 36 projects by March across the 5 key themes that you have on the page here. So it's ophthalmology, intensive care, mental health, urgent and emergency care, and anticipatory care. And the program is sponsored by Health Education England, NHS Improvement, and our training associates, and basically the program will have trained probably in excess of 70 people at the end of this year, including the 46 associates. That's probably there's lots more to cover, but I think that's probably all for now in terms of the program. So moving on to the impact assessment, which is what this session is about. We just want to touch on why we're doing this. And the essential is that the program's been running for about 3 years now and has had a lot of positive feedback and has grown in at scale. But we also feel that whilst the positive feedback is fantastic, we actually are committed to undertaking more formal economic assessments to better understand what impact the program is actually driving and how we can make it better. So in terms of the purpose of the impact assessment is twofold. It's first and foremost about informing our learning, because that enables us to identify opportunities to refine and develop and improve the program and drive better impact, which is what it's all about really. But also, just as importantly, it allows us to evidence the value that we create, in terms of economic terms, and making sure basically that our sponsors can see that they're getting the value for money that they for the investments that they make. And to that end, we have been working with some health economic experts, 2 teams actually, both from UCL's RREAL team, as well as with Jackie and her team from Economics by Design. And those two different parties have sort of brought both the process and the methodology and the research together. And you can say, well, why didn't we do it ourselves? Because, well, we took the view that that would be like marking our own homework, and we are not health economists. So that's why we basically passed it on to sort of the capable hands of these external experts. So that's basically why we're doing it. And I'm now going to hand over to Jack, who's going to introduce herself. She'll do a better job of that than I will, and then talk us through what the health economic landscape is all about.
Thanks very much, Tina. I'm going to do a Chris Whitty here. Next slide, please. Thank you. Yeah, so this is me. Tina asked me to introduce myself. I'm a health systems economist, and I am co-founder and director of Economics by Design. As Tina said, we've been working with the RREAL team to do the economic impact evaluation. I've been working in and around the healthcare space for over 35 years, and have also led many mixed methods evaluations, which I think is why we were approached to help CLEAR to have a look at the impact of the programme. Next slide, please. So I wanted to answer, if you like, 4 questions. I'm not going to talk about the impact of CLEAR. I'm going to let John do that. But I'm going to talk about some of the contextual drivers which informed how we did the evaluation. And the first question we're trying to answer is what drives value in healthcare? How do we look at value as health economists? One important question is, what is a value proposition? And what's the promise of value that we would expect CLEAR to be trying to achieve? How do we evidence that value? What methods and techniques do we use to try and substantiate that promise of value? And then finally, I want to just reflect on some of the tricky issues that presents, particularly when we're doing this kind of real world, real-time evaluation. So next slide, please. Let's start by thinking about what drives value in healthcare. Basically, there are kind of 3 big buckets of drivers. The biggest bucket by a long way is now recognized to actually be the wider determinants of health. So when we're looking at the value of health, one of the most important drivers are things like whether you've got a job, what type of housing you live in, what kind of environment you live in, what the kind of community you live in. And estimates from the past from McGuinness and colleagues have suggested that's as much as 45% of the variation in health outcomes is accounted for by those wider determinants of health. The next big bucket is actually what we do, how we self-manage, how we look after ourselves, what kind of diets, physical activity, exercise, smoking, use of alcohol, that sort of thing. And that's another 40%. Of the variation in health outcomes is attributable to healthy behaviours. So when we're actually looking at the contribution, the economic contribution of health treatment, estimates suggest it can be around 15%. Now that sounds kind of a small amount compared to the other 2, but it's not an insignificant amount, and it's enormously important. But we must always recognise that it's actually those 3 factors working together that contributes to healthcare value. And we've got lots of evidence now that a strong and healthy population drives a strong economy. And in fact, vice versa. Strong economy allows you to invest in wider determinants, invest in improving healthy behaviours, and invest in strong and resilient healthcare systems. So let's look at the next slide, and you can see this kind of virtuous circle, I guess. We've got your healthy behaviours and your wider social determinants on the left-hand side here, driving improved population health and health outcome, which is also influenced by your healthcare system delivering what we call value-based care. I'm going to come on to that in a second. And then if your healthcare system is strong and resilient, combined with that improved population health and health outcomes, that's what drives your strong and stable economy. So a virtuous circle here. Let's look at value-based care. You've probably heard of that mentioned. The European Commission recently defined it as having 4 components. On the top left here, we have technical value, which, if you like, is the productivity value of a healthcare system, how many patients you can see, or what outcomes you can achieve for a given resource. Personal value, which is the value to the patient, the value to the citizen, the value to the family, the carers, in terms of health outcomes and patient experience. Allocative value, which is how we think about the distribution of value across different population groups. There's a huge emphasis on that right now in terms of health inequalities and the need to address health inequalities through improving allocative value. I'm not going to use the term levelling up. There, I said it. And then the societal value, which is the contribution of the healthcare system itself back to society, and the value that that adds. So what does all this mean for something like CLEAR, program like CLEAR? The first thing, as I said earlier, is to think about what the promise of value is. So we were asking ourselves, what's the promise of value from CLEAR? And the promise of value needs to be set in the context within which it's being worked. So we're talking about what situations do you use a program like CLEAR to address? What's the unique challenge, if you like? What are the problems or the opportunities that a program like CLEAR can address? And what are the key design features of CLEAR? What are the mechanisms for actually delivering that? And we've heard Tina reference things like training and upskilling of clinicians. We've heard terms like big data. You know, what are those kind of mechanisms? What's their contribution to the generation of value? And then really importantly, how do you measure the value compared with what? Well, compared with the next best alternative, compared with what would happen in the absence of a program like CLEAR. That allows you to measure the differential value, the added value, or the value proposition. So at the beginning of your journey, you're thinking about what is our value proposition, what's our promise of value. I nearly tried to move the slides. Next slide, please. Hold my arm back. So healthcare value proposition really is just the connection between the context and the problem, the solution and the kind of use cases or service lines that solution's being used for, and it's in healthcare, the impact on the quadruple aim. So that's how does this improve the health population? How does it enhance the experience of care? How does it reduce the per capita cost of healthcare? And how does it improve the staff experience of care? Next slide, please. And when we're measuring economic value, we often look at the logic model behind the value proposition. So we're looking at the how. How is this supposed to happen? What are the resources that are going in? What are the inputs that are used? What activities or processes are undertaken? What measures can we use to check that those things have actually happened? You know, how many clinicians were trained? How many people participated in the program? And then what are the outcomes that have been achieved and the impact that that has? Now, from an economist's perspective, sorry, can we go back the slide? From the economist's perspective, we can look at the relationship between the resources and the inputs and see if actually what we're doing compared to the next best alternative is quite simply cheaper. And John is going to talk a little bit about this because we found some evidence for the CLEAR program that this is actually one of the value promises is that it's a very, very cost economical way of doing these kinds of programs. So that's simply looking at the economy of the intervention or the solution. If we move towards, sorry, can you keep on that slide? Sorry. If we move towards the processes, we're looking at the relationship between the inputs and the activities for a given level of output. And we can say to ourselves, is it a more efficient process? Does it do something more quickly? Does it do something more with better processes, more productivity? So the same level of input, you get a better output. And then on the when we're starting to look at the outcomes, we're looking at whether or not this is compared to the next best alternative more effective. So we're saying, does this achieve better outcomes? And again, I think John's going to be talking about what we found for the CLEAR program in relation to the potential to achieve better outcomes from using a program like CLEAR. And in health and care, the complexity of the message gets more complex as you move from the left to the right of this logic model, if you like, because actually measuring outcomes becomes really hard. You have to, especially if it's patient outcomes, you know, we're looking at some intangible benefits which we have to place a value on, and that becomes one of the tricky issues I'm going to talk about in a minute. So now, next slide, please. Thank you. So in this context, really, in the context of a program like CLEAR, we're looking at economic value from the perspective of personal value and technical value. So we're looking at the kinds of things like improved patient experience, improved health outcomes, shorter waiting times, all of those kinds of impacts. And then on the technical value, we're looking
that's fine.
Sorry,
Yeah,
somebody's got their mute button off. Thank you. The technical value, we're looking at, you know, maybe shorter lengths of stay, reduced admissions, avoidable admissions, reduced GP visits, those kinds of measures of technical value. So that's what we mean by economic value in the context of the CLEAR program. Next slide, please. And the other thing we need to think about is time. So quite often you need to invest and then get your benefits. So one of the things we're looking at with CLEAR, we can see it's a 24-week program. There then follows some implementation of change. The net benefits will come sometime further down the line, but they might be very lasting. They might last for a number of years. So we have to start thinking about when's the time to value? At what point did some of the benefits outweigh the costs that have gone in? And this is all about thinking about how you compare usual practice and the new practice that results from using a program like CLEAR. So that was another dimension that we had to think about. Next slide, please. Lots of different types of methods for cost benefit analysis. Don't worry, I'm not going to go through all of these. If you've done any health economics, you'll probably be very familiar with cost utility analysis, which is the common method used by NICE to measure new drugs and new medical devices. And you need to basically be able to convert the patient outcomes into quality adjusted life years. My go-to is cost consequence analysis. I like cost consequence analysis because it allows you to articulate the costs and the benefits, both in financial and non-financial terms. And you can present them on a kind of balance sheet so that you are able to take an overall judgment of the full economic value of what you've done. Next slide, please. Last concept I wanted to talk about, this is also very important. Economic value isn't the same thing as affordability. It's answering a different question. It's answering the question, value for money, is it worth it? Affordability is about, can we afford it? What's the budget impact? So in thinking about making a case for investing in a CLEAR program, or making a case for investing in the change that results from a CLEAR program, you've actually got to think about both. What's the economic value from this, and what's the budget impact? Can we afford it? Next step, next slide. So how do we evidence all this? Next slide, please. There's evaluation guidelines from the Treasury. The Magenta book is 2020, is fairly up to date. Suggests that we should be looking for policy for this kind of program. We should be looking at 3 types of evaluation. We should be thinking about process evaluation, which is actually answering the question of should this work? Can it work? How will it work? We should be looking at impact, which is, does it work? Does it make a difference? And we should also be looking at the economics, which is it worth it? What's the value? And you can see central to this is that logic model, which I referenced earlier on. They're all interconnected. It's complex because you can either look at this from a formative perspective, so you can use this framework to improve the design and fidelity of your program, or you can look at it from a summative perspective and actually look at what did we do, what did we achieve. In my experience, it's always a little bit of both, because it's, you know, most of the programs that we see in terms of service transformation, workforce transformation in the NHS take a long time to have an impact. So often you're looking at the effectiveness of the activities that you did, and the outputs that you potentially might have influenced. So that you always find yourself slightly bridging this formative and summative. And again, conscious that you should always compare it with what you would have otherwise done. So that's what we've tried to do in focusing on the clear evaluation. Next slide, please. So as I said earlier, the logic model, I'm not going to go back through this slide. I spent a long time on it earlier, but the logic model does provide the glue between those three parts of the evaluation. So that's how we did the clear program. We developed the logic model, we looked at the alternative, and then we use this as the glue for the evaluation. Next slide, please. And then last of all is thinking about sequencing and measuring. And here we're talking about whether or not we are, how we measure the impact of what we're doing. And so if we're looking prospectively at the promise of value, then we have to start thinking about how do we evidence as much as we can from other studies, from other experiences elsewhere, the impact that we are expecting this program to have. If we're looking with hindsight, how did we actually look at the study and look at the impact that it had in terms of measuring what would have happened in the absence of the program? These are quite complex issues. These are quite tricky issues. Next slide, please. And so I wanted to just finish on exactly that. And I think one of the biggest issues is making sure you understand the why. Why have you chosen to do this? Why are you using the clear program? The second tricky issue is, what are you comparing it with? What would you have done if you hadn't used the clear program? What would have happened instead? How different would the results have been? The third tricky issue is trying to keep it simple. These programs are immensely complex, always. So try and lift up and keep everything as simple as you can. That's what we tried to do with this program. How you source the relevant data, again, that's a very tricky issue. Making sure that you are using data that's trusted. Hello. There we go, sorry. Making sure you can isolate the impact without bias. Are we sure that we can attribute this to having run the clear program? Are we sure that we can attribute this change to what was done without introducing bias? And then always remember, try and include the intangible impacts. They are just as important as the things that you can measure, and just as important as the things that you can put monetary values to. So that's me done. I am now going to hand over. I think we're doing questions at the end, aren't we, Tina? So I'm going to hand over to John, who's going to give you the actual results of the evaluation.
Thanks very much, Jack.
So, Jack, thank you very much, and I'll go through the slides shortly to describe the results of the impact evaluation, but I will also couch that I am not a health economist, and so I may use some words when I describe the impact evaluation that are demonstrate my ignorance of health economics. Before I go and discuss the impact evaluation, what I suppose I will do just briefly is introduce myself and give a little bit about how I got involved in the CLEAR program, or started it a couple of years ago. So it's great to see a lot of people joining this call. My name is John Jeans. I am an anaesthetist in London. When I'm not anaesthetizing, I lead the CLEAR program nationally. And the reason that an anaesthetist, or a lot of people ask me why an anaesthetist would have an interest in workforce redesign, workforce modeling, and the reason for me is one, due to a patient experience, and it was my dad, actually about 7 or 8 years ago, who got the kind of care that we would not want our patients or colleagues or friends to have when he had a gastric cancer. And right from his diagnosis through to his death, it was very, very, very difficult to get him a good quality treatment. The only reason that he got treatment that that I think was reasonable was because I was in the system and able to advocate for him. And obviously not everyone is going to have that opportunity. So for me, the thing that summed up, or the thing that sort of, I suppose, disheartened me the most was when he died, because he actually got diagnosed in a reasonable time with a bit of help, had a very good operation from a good surgeon, because I was in the system, knew who to take him to. And then he had a reasonable recovery, and then unfortunately got an early recurrence. And for his palliative care, his wish was to die at home. So we took him home, but keeping him home was a real challenge. We got a syringe driver delivered the very next day after he got home, but there was no one to help us set it up, and no one to help monitor it and maintain it. So my wife and I, another anaesthetist, we got the out of hours GP to come to the house, give us a prescription, write up that prescription. We didn't obviously write that prescription up. We took it to the out of hours pharmacy, got it filled out, brought it back home, and then got on the phone to the hospice and helped set his care up so that he could be looked after at home until he died. And that was for the next 10 days until he passed away. And 2 days after he died, the team, the palliative care team, came round to the house and asked if there was anything they could do to help. And obviously, it was a little bit late by then. And that experience made me feel very, I became quite disillusioned, if I'm honest, and very frustrated. And I didn't want to be that frustrated colleague in the corner. So I took some time away from clinical practice through a very haphazard manner, got involved in a workforce modeling program. And you're talking to someone who had no idea. I mean, I looked at an Excel sheet and I was amazed by a count and a sum function 7 or 8 years ago. And obviously I've learned a little bit more. Apparently there's more that you can do with Excel than that. I've learned a little bit more over the last couple of years. But what I also learned in that program is that if there was so many good people in the NHS, and there was a lot of data, but not the opportunity for people to use that data well with good quality conversations to design models of care and workforce that align to patient need. And so I saw, not just with my dad, but I'm sure there's many other people across the country who don't have access to the kind of care that enables them to live the best possible life. And so I started to do these, based upon that learning from that workforce modeling program. I came back into clinical practice and I've been part-time for the last 5-6 years now. Started doing individual projects to just help colleagues use data to redesign models of care and workforce. And after doing a couple of these projects, I was very fortunate that HE came along and said, "Oh, John, this is really interesting stuff. Do you want to design a sort of training program to train other clinicians to do this type of work?" And that's where the clinically led workforce activity redesign, or CLEAR program, came from. So I'm really very, very, very pleased that Jack and other colleagues have had the opportunity to look at the program, because as Tina alluded to, this program's been developed sort of in a very organic manner to try and address a need that organization systems and patients have, so that we can upskill staff and get them involved in the redesign of care in a way that's locally relevant and relevant to people in place, so that any change that can be implemented can be done so with good quality buy-in and in an effective manner. And so this is in essence, I'll just share some slides now, and please flag if you can't see them, but this is in essence the, oh, I'm going to scroll all the way through, my apologies. I thought I'd said current slide, but I haven't. This is the essence of the CLEAR program. So the aims of the CLEAR program are to create a clinically led culture that increases the ownership of clinicians and operational teams. So it's very important, multidisciplinary teams across clinical disciplines, HR, finance, workforce, and operational management. So it's to create that ownership of the challenges that we have in health and care, and not just the ownership of the challenge, but also the ownership of the solution as well. The program also builds new skills in colleagues that they can use to deliver the projects, but also design and then embed new ways of working within organizations and systems that provide effective and sufficient solutions to complex change, to the complex change that's required. And then most importantly, I think in terms of having a good chance of these things being implemented well, giving clinical ownership to those solutions in a way that bridges, as I said earlier, different disciplines within the workforce. And so the purpose of the impact evaluation was to first help elucidate that these are the key drivers for the program, but then also test whether or not they were achieved by the program. And so the evaluation methodology was a mixed methods analysis that was based on a series of interviews, questionnaires, a review of the report from previous sites that have been participating in the program, and also the recommendation, review of the recommendations and reports that came out from the sites that participated. And the evaluation was done on the sort of initial pilot phase of the program. So this was 2019 to 20. And the assessment was formative because in essence, there was this pesky virus that turned up in March of 2020 that meant that we had to radically reshape and redesign the program from its base after everyone, obviously myself and other colleagues got pulled off into various different projects in intensive care and all the rest of it. So this is the rationale for designing the methodology in this way, and then obviously future economic impacts will therefore have summative components. So I'll just go through the high-level findings of the economic impact, and I'll feel free to ask questions as I said. I'll go through this relatively quickly, but to allow time for thoughts and questions. But if there are, on that note, so the key finding one, and there's about three or four, is that through doing the projects, there is far higher clinical ownership, which generates significantly greater chance of implementation compared to the standard baseline programs of this type. So the implementation rate for complex change is low, between 30 and 90%, and on average from the literature review that was done by the RREAL team, there's only about 40% are implemented. And what was found from reviewing the previous sites that had done the work and participants is that, and participants in the program, is that there was a high, virtually all, the vast majority of participants thought that it was any clear project was far more likely to be implemented than if anything was designed in it using other methods, and that it was actually a more effective way of delivering these kinds of projects. And so that gave the basis for performing a sensitivity analysis, which indicates that there is a much significantly higher chance of implementation, about greater than 60% as opposed to 40%. And therefore that generates a significant return on investment when you compare CLEAR with an alternative, which would be another method of delivering a complex change program. And there was 2 case studies that were analysed in detail. One was at Blackpool Teaching Hospitals, where one of the key recommendations was the creation of a frailty unit, which had a significant opportunity to reduce the number of admissions with a significant cost saving associated with that. And given the cost of the project and the likely savings. The cost of the project is about 120,000 pounds, with the likely benefit of that, even if you discount for future savings, even if you discount future savings, was around 1.64 million. So that's an ROI of 14 to 1. The second case study that was done, analysed in detail, was at Calderdale and Huddersfield, and the changes there were again around the changes to the same day emergency care, which would again projected to have a significant impact on the number of bed days over the sort of the subsequent 5-year period. And again, when you compare the cost of the programme to the potential benefit here, the return on investment is about 4.54. Now, some people do ask, say, well, this is great, but have these findings were done a year and a half ago and presented at an executive level year and a half ago. Have these findings been implemented? And what's the impact of the implementation? Well, it's actually quite difficult to say. So, for example, at Calderdale and Huddersfield, they have now created the frailty unit and are now starting to see an impact from that. But for the last 18 months, the space that they wanted to use the frailty unit was turned into a hot COVID ward to look after COVID patients. So because of this pesky virus, a lot of the changes are now being implemented, but it is quite, it's just, there were significant operational changes that were necessitated just through patient need in March of 2020. And so those are only kind of reverting back now to type from the projects then. So that's just to sort of address some of those questions that have been asked in the past. The other point, so that was the first finding, is that CLEAR is more likely to be implemented, and therefore there's an economic benefit in that respect. But the second finding is that when you compare CLEAR to an alternative, it's more cost effective. So if you look at the types of problems that you use CLEAR to solve, CLEAR, if you think about your problems in an organizational system as being simple, complicated, complex, or chaotic, CLEAR is the kind of solution that you use to target complex or chaotic solutions. You would not use CLEAR to, I don't know, solve a simple process issue within an organization. There's other methodologies, there's other programs for that kind of work. So it's the kind of thing that you would get, the kind of problems that you would get external consultancies or advisors to help solve is the kind of thing that you target CLEAR at. And if you were to compare the cost of a CLEAR program in terms of number of days of the time it takes to deliver versus the cost of taking those same number of days and charging them out at a sort of standard consultancy rate aligned to G-Cloud or the MCF, Management Consultants Framework, what you find is that CLEAR is significantly cheaper than the alternative that's out there. So the cost of external consultancy is up to sort of just over £200,000, and the cost of CLEAR is about 115 for these projects. So the ROI from using CLEAR, just from you starting to use the program, as opposed to alternative, is about 1.9. And then the third finding that I think is important to state is that it's a really good development opportunity. So the way the program works is that the organizational system decides to do a project. The project is delivered in there's a CLEAR project team created within that organization, and that team is then supervised and trained by the CLEAR supervision by the national faculty, which is hosted at East Lancs Hospitals Trust, and so it's supervised by the national faculty and then trained with an education program. And so the CLEAR team in the trust does the project, and they then own the recommendations and the results and present the findings at an executive level. And this is a very, very, very good development opportunity for participants in the program. And so what we found from doing the qualitative analysis is that this was one of the findings, is that this was borne out. And so there was an analysis that was done to look at from the qualitative analysis, does clear increase the job resources and engagement, and therefore the intention for colleagues to stay within the NHS, or does it increase the job demands and the levels of exhaustion? And the findings from it were that although there was some increase in the job demands because people were taken out of their comfort zone a little bit when they do these programs and having to think quite differently, it significantly improved the job resources and that's the sort of autonomy to be involved, to be sort of a creator and own the redesign of services within an organization, and also significantly increased the staff's engagement with the delivery of services and the design of services within their organization. And so what this then meant, and I'm just moving my chat bar from one side to the other to just look at the other side of the slide, is that there's a likelihood of this retention benefit from this analysis. And if you look at, and this was just an example done on one of the trusts, if you look at the value of a labour and needy department in one of the trusts, it's around £2.7 million with agency spend. And given the turnover intention within that organisation, that's quite significant, and that's quite a significant cost if you lose a number of your staff within a particular trust. There's just a cost associated with hiring and with the replacement and the loss of that knowledge. And so the cost of Clear project being about 116,000 for these projects that were done. All you need is 1% of those staff from being impacted upon by the Clear project or from doing the project themselves to choose to stay, and the project's paid for itself. So that was sort of the third finding from the program. And I suppose the last finding to discuss is that people like it. They which is really reassuring, because obviously when you invest a lot of time into something, over the last couple of years, I constantly worry, are people having a good experience of this work, and are they actually, is it making them more effective and efficient individuals, and are they able to take that knowledge and use it in other ways, not just from the Clear program, but in their other elements of their career. And so what's been quite pleasant from seeing the results of this evaluation is that people have learned new skills. They've been able to be more relevant and responsive and engaged with their own organizations, and a significant portion, a majority of people have significantly improved by their have significantly had positive impacts on their career progression as a result of doing this kind of work. And I mean, there was a case from one of the ongoing UEC projects where there was a doctor applying for his consultant interview, and in the middle of his consultant interview, he turned around and started presenting to his interview panel some of the findings that he'd done with his Clear project, and showing some of the analytics and some of the new changes that were going to be implemented. So a little bit of a segue, but it's really nice to see that these are the kind of things that are coming out from the economic evaluation. I'll stop there, and I'll just before taking any questions, just ask Jack quickly. Jack, I am a novice when it comes to health economics, and I may not have used exactly the right words in some of those findings. And I just wondered if there's anything that would be worth clarifying, given the language I've used, or any points that are worth reinforcing there.
I thought you presented that really well, John, and it's a good example of where we need to combine those kind of different perspectives of the economic efficiency. So there's the cost economy, if you like, there's the cost efficiency of doing this compared to giving it to external consultants, for example, to try and stimulate these kinds of changes. There's the cost effectiveness in terms of really the stickiness of the programs, which is the likelihood of them succeeding because they're owned by the clinical staff. And then there's all the kind of intangibles which are really important around workforce retention. I mean, they're not intangible actually, but around measuring the impact is very difficult to do. But around workforce retention, workforce satisfaction, skills development. These are all really important perspectives of value, and economists, do think they should be included. Just because they don't have a pound sign in front of them doesn't necessarily mean they shouldn't be included. So no, I think you presented those different dimensions very well. And yeah, you can do the next one.
Well, thank you, Jack. And I guess conscious there's been quite a lot of talk over the last sort of 45 minutes or so, but I was just wondering if there's any questions from anyone on the call. And we don't have a huge number of people here, so if people want to take the camera off and take the mic off and ask questions or raise hands, that's also absolutely fine. Or write questions in the chat. So Emily, how often are the impact assessments conducted? So that's a really good question, Emily. So the we had an ongoing, we basically have continuous impact monitoring and evaluation of the program. So we take regular feedback from the participants in the program and the trusts as we go along, so that we can, just part of our own internal governance really is to make sure that we spot any issues and can ensure that people are feeling supported and able to deliver projects that answer key questions, key priorities in the trust, and also for regional and national sponsors. We're looking at the way the program's lined up is we have different themes. So there's a mental health theme, as Tina alluded to earlier, a primary care theme, urgent emergency care, critical care. And what we do is we have the ongoing monitoring and evaluation, and then we also at the end of each theme then look back and take all of that ongoing monitoring evaluation and then review it to see where what the impact of that particular theme has been. So that's the sort of current process of how we look after them. So the answer to your question is that at least once a year, but it can be more frequent depending upon the number of themes that we're running as a program. If that's helpful.
So if I can just add to this, I think this is the first time we've done sort of an external and as thorough impact evaluation with a sort of economic focus in the way we've done here. And Caroline just published the link to a very nicely looking brochure that summarizes all this as well. And the intention is that will be updated regularly as the programs conclude. But as John said, well, it's once a year that we do the glossy brochure. There might be the case, but internally the evaluations are running kind of throughout the year because it's an important part of our own learning and development.
John, I had a question. Are you looking to make any refinements to the programme following this initial study?
You're on mute, John.
Fraser 2021, you're on mute. So that's a good question, Caroline. What we've done as a result of this impact evaluation is we've changed the way that the education is delivered and the way that participants are supported through the program, so that the program can be more scalable and more accessible. The other things that we are doing is we've looked at how we can support organizations to evidence implementation. So one of the things that we struggled with when COVID hit was that everything was thrown up in the air, all the pathways were changed, and it was quite difficult to get organizations back on saying, okay, but this is what your plan was, this is what the report was, how have you sort of been able to progress it? So what we've done now is set up ways to try and ensure that organizations embed and monitor the findings from the program in a slightly tighter way. So that's been one of those have supposed to be the key changes that we've had from the evaluation. And we're also changed, as a result of doing the evaluation, it changed the way that you evaluate the program going forward, because you look at other methods for once you understand the value that you're bringing in terms of the value proposition, it's then far easier to put in place more effective metrics to manage the program going forward. So those, I'd say, would be the key changes. But it's actually a very good question. Yeah, thank you.
Can I just chip in as well? Because I think the other thing is, it's again slightly less tangible. But once you have identified the points of value, like the stickiness, like the economy, like the workforce training legacy, like the workforce retention through the experience of doing this, and feeling like you've got some control over your the future of the work organization in the trust, those impact on the design of the program. Those will impact on the design of the program. It's even if it's like subliminally, as you start maturing and developing programming, and think, how are we going to make it more sticky? How are we going to make it more of a good experience? How are we going to ensure the training leaves a legacy? And it's not just about measuring it, it's about the designing the value into the program as a result of the evaluation. And I can see that sort of happening in the discussions with the team. So yeah.
Yeah.
So I've got a question for you, Jack. I've got a question for you. So basically, you've also done lots and lots of these economic impact evaluations and assessments, and looking at the CARE program compared to other complex intervention programs you've seen, how promising is what we do, and how does it compare? Because obviously we think it's marvelous, but just how does it, how does it compare based on your prior experience?
It's a difficult one because it's still very formative. I think potential is very strong. The value proposition is very strong. The theory of change is very grounded. I'm as an economist, I tend to err on the side of scientific positivism. So I like to see cause and effect, and to measure it. But I'm also a bit of a realist in that I can see that the world doesn't work quite like that. And this is very grounded. The concept of clinicians having control over the changes that will improve the patient experience, improve patient outcomes, improve the staff experience of care, that quadruple aim, whilst at the same time, getting more value from the resources that are being used, from the budgets that are available. I think this is a very promising intervention. I'd like to see the evidence be built up in terms of just how sticky these programs are and how much clinicians carry on using the skills that they have developed as part of being part of that program. But yes, it is promising. As you say, a lot of the work I do is on complex interventions where you can't do a random assignment trial, you can't safely attribute cause and effect without, bringing lots of different factors together and triangulating the research. So it's no different in that regard at all.
Well, that's reassuring.
Well, Jack, thank you very much for coming and speaking today. I really appreciate it, and thank you everyone who's been able to join. And we'll make sure that we send out links to the recordings, to all slides, to all who could attend and those who couldn't. So have a great day, everyone. Brilliant. And yeah. Have any questions? Thank you.